Today I'm going to present quite a complex case of a very young patient who came to us after surgery on the acoustic nerve with a very troubled medical history. Started in 2016 with a surgery for partial neurinoma that has been repeated later after developing a microcephalus that was treated with derivative surgery, which entailed actually greater complexity of the case, especially from the neurological viewpoint. So this is the best eye, the one contralateral to the lesion of the nerve, and the visual acuity is very low and compromised by the fact that the hydrocephalus determined a secondary pathology of the optic nerve with atrophy that is worse in the contralateral, so in the fellow eye, where there hasn't been any expansive lesion to the acoustic nerve. And this is the best eye in terms of visual acuity, the one that developed a neurotrophic ulcer. And here again, she presented to us quite late. After a number of treatments, you can see on the slide, so bandage and tetracycline, and with central corneal ulcer and an epithelial defect. We shouldn't define it as an ulcer, because if we consider the updated classification, the one published in a paper published by Minder Dua, is the mild or moderate disease with an indication to treatment with the AMGF. So what should we do in order to define and diagnose correctly this patient? This is the question. Okay, let's have the votes. I think we all agree to be sure, measure the sensation if we have a boucher bonnet, but here there isn't. So touching the cornea of the patient, and we should remember that we should touch from the periphery to the center with a very simple maneuver with a cotton tie. So it is also very useful, as we said this afternoon, for these patients having an epithelial defect, to think of a possible form of herpetic keratitis. So PCR may help us, and corneal scraping may help us understand, whereas there is also a herpetic co-infection. So we went for both these strategies. So corneal anesthesia, lab tests negative. Okay, the answer has been revealed too early. Of course, there was a palsy of the seventh left cranial nerve. So what should we suspect? So moderate grade or mild grade neurotrophic keratopathy plus keratopathy from exposure, which is the case here. So what to treat first? So what should the approach be? Rika gave us in her overview a very clear picture and outline of what should be done in such cases. Apart from the classical coverage medical treatment, So the answer is we should treat lag of thalamus and obviously the corneal ulcer. Consider this patient has a single eye. This is the best eye because the other one doesn't see at all. Okay, we started treating the patient. We started with the trial weight and then the gold weight because this is the prerequisite to maintain a good blinking and so to preserve the function. So first of all, the temporary weight was applied, and then the final, the definitive weight, so the gold weight inside the eyelid. So we all agree on this case, apparently. So, however, the surface should be protected, allowing for a good closure of the eyelids. How to treat the epithelial defect? Let us see.
Ecco, anche qui siamo tutti d'accordo.
Here again, we all agree, mostly. So prophylactic antibiotic treatment or plus lubricant with no preservatives and contact lenses may help us. But then there has been a quick deterioration and consider that it was around Christmas last year and VGF weren't available yet. So I asked for compassionate usage of VGF because it was the only chance we had to try and preserve the anatomic integrity. So we had to ask to apply for the approval of the ethical committee and the order, but we actually it was too late. So the situation actually deteriorated, so perforation occurred. What would you do after the perforation? The decimatoceal after the perforation was quite extended. Okay, the result? Again, we aren't 100% in agreement, no classical PK, because the tectonic penetrating keratoplasty might be used successfully in these cases. But the conjunctival flap, it's an idea, but actually there you get a net reduction of the visual acuity and patching with cyanoacrylate with in such a perforation, such a big perforation wouldn't be a good idea because, however, there would have been a passage into the anterior chamber and then it would be disabling. And this is what we did, and we were successful, but the visual acuity remained very poor. And so now we have considered the situation. We waited for some time. We waited for the clinical picture to stabilize, and then okay. And then since the patient actually demanded us or required something to be done, and I've also consulted with colleagues, we decided, we opted for an optic penetrating keratoplasty. So I was wrong, actually. I gave the answer too early, but we might have waited had the eye been good. And after restoring the anatomy, I thought that since the MGF was in the fridge at this point, we might run the risk or take the risk. So I have to say that we all agree at this point. Why was it perforated? Vincenzo, what do you think? With the amniotic membrane, we closed the perforation. And then if you remember the picture, we didn't have any other chance, actually. No, they didn't have the leeway to do so. Um, when we took the patient to the operating room, actually the membrane was perforated. Yes, but probably we aren't as good as Donald, but however, over time we did learn something. It got stuck, guys. Okay, here we are once again. So the MGF was in the fridge, the MGF was in the fridge, so we performed the keratoplasty, the epithelium was okay. After 10 days, epithelial defects emerged, and so we got into stage 2 neurotrophic keratopathy within and without limb, the flap. So NGF treatment with eye drops according to the suggested regimen or scheme, therapeutic scheme, the recommended one. So the epithelial defect uh, slowly closed, and if necessary, a suture. No, it wasn't necessary because we had a peripheral cheese wire, but it wasn't really an issue, so the defect actually closed up. And at the end of the 5 weeks of, or 6 weeks of treatment in May, the cornea healed, and we were left with a very mild opacity. And then we discontinued the medical treatment, and immediately the situation got worse. So the story is not finished because we had to redo surgery to reinitiate NGF treatment, and this actually raises some doubts as to the ability of NGF to manage post-op situations. So we have a lot of work to do on this, and so I've submitted a question to the advisory board in Barcelona, and there has been a lively debate on how to manage the nerve growth factors in post-op clinical situations. And this is a question that probably will be the subject of next study by Leonardo. Leonardo probably will have to say something about this, how to improve the prognosis of these patients. Then, of course, the situation is still ongoing, but we may say that today the situation is not too bad, and we think, in agreement with many others, that we should try and prolong NGF treatment for several months after surgery in order to preserve the clarity of the surface. But there is a question mark, and a severe one, a big question mark on our ability to use the subepithelial or the cornea of the